はい、録画させて、このセミナーを録画させていただきたいと思いますので、よろしくお願いいたします。ラファエル・エスカミーラ氏はですね、私がもうだいぶ前ですが、SMID の頃の、メンバーの一人で、プレーンプライスですね、野球関係者などをよく知っている方だと思いますが、その方と共にですね、アメリカンスポーツメディシン・インスティテュートの野球科学研究を進めた立役者の一人ということで、皆さんも名前を聞いた人が多いのではないかと思います。で、今日はですね、60分という非常に短い時間でのセミナーになりますので、自己紹介等は非常に簡単に終えて、エスカミーラ氏のプレゼンテーションに行きたいと思います。Okay, now we have only 60 minutes for this seminar. So I want to introduce you just very briefly. Okay? Professor Vasquez Camila works with California State University at Sacramento. He is a professor of physical therapy and co-director of biomechanics laboratory. Then he has a lot of plenty of scientific papers. These are the recent throwing-related papers. He has over 200 scientific papers. In addition, he is not only a scientist. He had 3 continuous international powerlifting championships from 1993 to 1995. So he was a very pioneer of the two-way research. Okay, please, Escamilla.
Thank you very much. I want to start by thanking Professor Tomoyuki Matsuo, and Tomo and I met, as well as Professor Yoshi Takada in the audience. We both, all 3 of us, have worked together for about the same amount of time. We met in my country, in the United States, in Alabama, in the early 1990s. And that's been 30 years ago. And we've been working together. We started our research then. And when we started, Professor Takada and Professor Matsuo, myself, there was hardly any research done in biomechanics of baseball pitching, very little in the scientific literature. Now there's a whole lot more thanks to our professional esteemed colleagues, Professor Yuki and Yoshi, and the work that I've done as well, and our friends in Alabama, of course, Dr. Pleisig and Dr. Andrews, Dr. Kevin Wilk. We've all worked together, and we continue to work together to this day. So just want to start by thanking them, as well as just the honor to be here in Japan. My wife Yana in the audience, we've been treated so well, and we're so happy to be here. And such a beautiful, first time in Japan, and I'm so impressed with Japan. I can live here. I can live in Japan. There's just so much beauty here, and tidiness, and structure, and the list goes on, and the hospitality of the people here as well. So thank you very much for inviting me, Dr. Matsuo, and of course Dr. Takada as well. So this is my talk that Dr. Matsuo has commissioned me to give at this seminar. And we're going to be looking specifically on the biomechanics of the pitching elbow. And so really, we started this, like I said, over 30 years ago now, really tried to enhance mechanical efficiency. So that's really what we're trying to focus on. How can we improve mechanical efficiency? On the one hand, if you have better mechanical efficiency, your injury prevention, we believe, goes down, is improved. This occurs by decreasing forces and torques on the joints, of the elbow as well as the shoulder. And also this produces a decrease in tissue stress onto the elbow. Also, you have better mechanical efficiency, you have decreased energy expenditure when you pitch. That produces decreased fatigue, increased stamina, and that also can result in decrease in tissue stress. Of course, we're interested not only in injury prevention, but we're interested in enhancing performance. And we believe that you can improve your mechanical efficiency. Your performance can also improve by increasing control and increasing velocity. We've studied a lot of pitchers over the years at the American Sports Medicine Institute, where Yoshi and Tomo and myself started off. Over 1,600 pitchers now that we've studied, a lot of professional pitchers, high school, college, recreational. We've studied a lot of the best pitchers, our Cy Young Award winners. All these folks you see here have been in our laboratory. We've been able to research so we can kind of establish a database on how do the best professional pitchers throw. In that database, we compare others to that database to try to improve performance as well as minimize injuries. So we started this, and back when Tomo and Yoshi and I started, we didn't have color video, we had black and white, the old Kodak film and tape. But now we've evolved to nice color, high speed. This is a professional pitcher throwing 40 kilometers per hour in our lab. If we just watched it at regular speed, it would be a blur. But really look at it in slow motion, appreciate the stretch of the muscles, appreciate as he's accelerating and decelerating. Look at the posterior musculature. There's really a tremendous amount of loads that go on in pitching. So we kind of started this 30-some years ago, looking at qualitative analyses of high speed. And from that, we developed hypotheses that, loads look pretty high. We might want to look at the shoulder and the elbow. And from that, we developed into quantitative analyses. So this is our laboratory at ASMI. We put all the reflective markers on. Of course, nowadays we put a lot more than what you see here. Pitching down, there's all these cameras that go around. All they see is the markers, and they track the markers as they move in space. And of course, you can see here. And if you have markers on a joint, for example, if you have a marker on the shoulder, the elbow, and the wrist, you can use law of sines, law of cosines to calculate angles. And then you can use first and second time derivatives of calculus in order to calculate linear and angular velocities and accelerations. So that's our kinematics that we look at in pitching. And that's what we start with, is it describes how the motion occurs. And that's why we're interested, because we want to know how is the motion occurring. But it doesn't explain why the motion occurs. So we have to go a step further from quantifying elbow displacements, velocities, accelerations, and we want to look at the kinetics, which explains why the motion occurs. And also, we want to quantify the muscle activity, not just the elbow forces and torques, but how active are the muscles? What muscles are on? When are they off? How much are they on? So we can gain a little bit of understanding of muscle patterns, and that can help us both in training and rehabilitation, as we know how the muscles are firing, and also are they firing eccentrically or concentrically, because we want to have the specificity of training in our rehab and training programs as well. So if we look at the pitch, it starts with a good windup, a good balance position as you see here. And from there, we go to our stride for that balance position to lead to a contact. Not a lot of forces going on here or torques, but these are very important positions to start with, because if your lead foot, for example, lands too open or too closed, or your foot is pointed in too much or out too much, or your arm is not high enough or too high, or you're late and rotating your shoulder back, all these can cause later increases in shoulder and elbow forces and torques later on in the pitch. And this is where you really get your highest amount of loading is in the arm cocking phase of loading here. Imagine the amount of stresses. Just look at this picture. It looks painful to look at. So the arm cocking is where we have very high loads. And then of course you go into arm acceleration and continue, but the loads are even higher in arm deceleration. So you go from cocking to arm acceleration to ball release, and then for ball release to max shoulder into rotation. That's when the arm is slowing down. So again, we have very high loads occurring, and then a gradual follow through helps dissipate the forces as well. So, like I said, the wind up and stride, as you see right here, low to moderate elbow muscle activity. But it's important that you keep the right sequence occurring here, because if not, the loads that occur later in the pitch is affected, as you see right here. So that's why we're very cautious to see the position of the whole body in this wind up and stride position. So you can see a couple of things we looked at is this nice 90-90 position, 90 degrees of elbow flexion, 90 degrees of shoulder abduction. Very important to have initially at least for contact, and then of course the arm able to rotate up adequately. So we're going to spend a lot more time on arm cocking, because this is where the loads at the elbow are very high in this arm cocking phase. And the highest stress at the elbow actually occurs in this phase, as well as the arm deceleration phase. So we're now looking at some elbow pathomechanics during the arm cocking phase. So first, we're going to focus on medial tensile injuries. You might notice the ball wasn't supposed to go over there, and he was in a bit of pain. So he just tore his ulnar collateral ligament on that pitch. And so when you're pitching, you're putting a lot of tensile loading on the medial elbow. And that's what it's showing here. And the main constraint to this is the ulnar collateral ligament. And that's what oftentimes is injured in our baseball pitchers. So you can see in this diagram, the UCL actually has three bundles: an anterior bundle, a posterior bundle, and a transverse. And it's the anterior bundle that is ruptured in the overthrowing athlete. And that's the one that's put under the greatest amount of strain. In valgus, when you go in a valgus position from 30 to 120 degrees of elbow flexion, and that's basically the range that occurs in baseball pitching, most of the range. So you can see as the forearm goes into a valgus position, or elbow valgus as we call it, that there's going to be tensile loading on the static restraints, with the UCL being the primary one, where there's a lot of strain going on in that particular tissue, the anterior bundle in particular. So also we've done research over the years to look at overuse injuries and throwing high stress pitches, such as curveball, slider, and also poor pitching mechanics. All these have been shown to some degree to increase loading on the UCL. So we want to try to improve these by varying volume of training, intensity, what type of pitches are thrown, and improving your pitching mechanics as well. So, do we really need to focus on UCL injury prevention? Is there really a UCL injury problem? Good question. And the answer, of course, is yes, there is. Just looking at these positions would lead one to believe that this is putting a lot of strain on the elbow, and is not a normal, natural thing to occur. If we look at injuries in professional baseball, and this is primarily in the United States professional leagues, but I'm sure it's quite similar in Japan professional leagues. Hamstring strain, rotator cuff. If I look at where the UCL is, it's right up there toward the top. So as you look at this list of injuries, we have our Japanese colleagues out in the audience. Can you confirm, are these kind of the main injuries you guys also see in the Japanese professional league? Do those look similar? to the injuries you see? Okay, yeah, so the UCL is right up there. We have over 1,000 injuries, as far as number, 300,000 missed days because of injury in this ligament. And an average length of 275 days. So it really is a very lengthy, costly problem in professional baseball. So we're really trying to understand how we can prevent these injuries from occurring. You can see again in our professional baseball leagues in the United States, 1 out of every 4 Major League Baseball pitcher tears their UCL. That's a very high number, 1 out of every 4. A little less in our minor league professional baseball. And also look at the revision rate. It's significant as well. 13% of those that tear it the first time are going to go on to tear it again. So it's really a big problem, again, why we want to try to prevent these injuries. If you look at the epidemiology of ulnar collateral ligament reconstruction in major and minor league baseball, a lot of reports, over 1,400. Between the first one was Tommy John, who was a real pitcher. A lot of we get that question a lot. Was there really somebody by the name of Tommy John, or is it just the name of the surgery? No, there really was someone named Tommy John. And he was the very first case of having his UCL reconstructed and returning to play at a high level. Before 1974, when you ruptured your UCL, your professional baseball career was over. There was no way you can continue. But in 1974, Dr. Frank Jobe, and there's Dr. Frank Jobe, he was the team doctor for the Los Angeles Dodgers. And the Los Angeles Dodgers just picked up 2 your most famous Japanese baseball pitchers recently. I live in California. Los Angeles is in California, but I live in Northern California. We have our San Francisco Giants. So I'm not very happy about it. I wanted your 2 pitchers from Japan to come pitch for the San Francisco Giants, but they didn't. The Dodgers outbid them, and they're pitching for the Dodgers now. So, but maybe we're still getting them someday. But he was the very first one. And he didn't want his career to be ended, so he talked Dr. Jobe into doing really kind of an experiment, because it'd never been done before. You know, he doesn't know if it's going to work, is it going to turn out? He just did some work on cadavers. That's really the only work that's ever been done up to that point. But he did the first surgery, and he pitched at a high level for another 12 years roughly of his career. So he had over a 20-year career, first half of his career towards the UCL, and then he went on to pitch at a very high level. And that was the start, 1974, of the reconstructions that occurred. You can see between 1974 and 1994, there aren't hardly any surgeries. So it took this, because there's only one person who knew how to do them in 1974. Dr. Frank Jobe. Now there's many orthopedic surgeons in Japan, United States, and around the world that does these surgeries routinely. So you can see the surgery numbers are going way up. Part of the reason it's going way up exponentially is because the injuries are going way up exponentially. So we really want to focus again, how can we prevent these injuries? Even the revisions are going way up of late. The revision rate as well is relatively high. So if you tear it the first time, you know, there's a certain percent, as you see down here, that's going to go on to tear it again. So another reason we want to try to learn how to prevent these injuries. Who is getting these injuries? Well, it's baseball players. Now, of course, not just baseball players. We see them sometimes in tennis, volleyball, but not very often. Really, it's baseball players. And in particular, it's baseball pitchers. You can see roughly 900 pitchers, 800 of the 900 baseball players are the ones that tear their ACL. Catchers, not very often. Infielders, not very often. Outfielders, occasionally, but not very often. So really, it's the pitchers that we're trying to improve. About 84% return back to any level and about 73% return back to their prior level. And the time to the prior level is about 60 months. So it's a very long journey to get back to the same level or at least some level of pitching. And these outcomes you see right here are much better than the shoulder. Okay, if you injure your shoulder, in fact, shoulder surgeries are going down in professional baseball. But as we know, if we do surgery on the shoulder, their outcomes are not very good, especially compared to the elbow. At least the overwhelming majority that do the UCL reconstruction are getting back at least most of them to their prior level anyway. So we did a study, myself and my colleagues at the American Sports Medicine Institute, where Joe Moriyoshi and I all worked. We did a study recently through a grant from Major League Baseball in our country. And it was the first study ever where usually we have these pitchers come to our laboratory and we put markers on them like you saw in our lab and we study them. In this, we actually took our laboratory to them in spring training. And we went to 10 professional baseball teams during spring training to try to look at the mechanics of those that had a UCL injury and those that did not have a UCL injury. So we matched the 40 professional pitchers with UCL reconstruction 1 to 4 years ago, 40 matched pitchers without reconstruction. And the goal here was to see, when you get the reconstruction, do you return with the same pitching mechanics or does it change? And we found the bottom line, what did we find? This is just a few of the variables, kinematic and kinetic, such as varus torque. But we found that those that injured their UCL and had it reconstructed, they basically have the same pitching mechanics, kinematically and kinetically, as the ones that have never injured their UCL. We hypothesized that because the outcomes are pretty good. So we hypothesized that they would come back to the same mechanics after the UCL. So it's a pretty good return. All these people made it back. Tommy John, the first one in 1974. All these Hall of Famers, some of the best pitchers ever to pitch, made it back. But they don't all make it back. How about this person over here? We don't know about these 20% of the professional players, and of course, I'm just talking professional right now. What about all the college and high school players that it's really going up on as well, these injuries? They don't all make it back. So we don't want to say, well, don't worry about if you injure it, you can always get Tommy John and you can make it back to a pretty high level. Now, because a lot of them don't make it back still. And the ones that do make it back, some of them go on to re-injure. So it's not something you want, but we know that those who make it back basically have the same mechanics as others and the same performance as others as well. And like I said, I'm mainly talking about professional pitchers, but here's some data in youth pitchers, 15 to 19 years old, and you can see there's really been an increase in the UCL injuries in this age group. So it's alarming. A lot of these younger players in the United States and Japan, young pitchers under 20 throwing very hard, 35, 40 kilometers per hour, and they're injuring their UCLs. And they never used to injure it at this young age, but now we're seeing a lot of injuries in our youth. So it's really becoming a big problem at all levels of baseball. And baseball being so popular in Japan and America, it's something that we really need to continue to study. So here you can see there's a new technique, relatively new, that's out now where we do repairs of the UCL. So traditionally, we've always done the reconstruction, but remember they take a long time, 12 to 16 months to recover. Well, if you're a high school pitcher or a youth, maybe you're not going to go on and play anymore. You only have 1 more year. You can't afford to wait 12 or 16 months because you'll be done. So they've come out with a technique now to repair them with internal brace augmentation. And this technique was kind of founded again with the folks, orthopedic surgeons that Tomoyoshi and myself have worked with at the American Sports Medicine Institute. They've done the most research on this early on, and they found that 92% of those who desire to return to the same or higher level were able to do so in only half the time, about half the time. So this is promising. Instead of reconstructing it with using a synthetic tendon or another tendon from a muscle, now you can simply repair the damaged ligament and reinforce it with internal bracing and not reconstruct it, and they get back much quicker. So, but in professional baseball in Japan and in America, no repairs at this point. We still do the reconstructions. It's still too new to see the outcomes, and it's only been done in amateurs, high school and college. So it hasn't been done in professional. In America, I don't think it's been done in professional in Japan. I don't know if anybody in the audience can confirm that, but I'm pretty sure that's the case, or if it has, it's not very many. So UCL repair with internal brace augmentation, like I said, is viable for amateurs, but we still don't know about their use for professionals. Maybe in time, these repairs will become better, and if they are better, we can do them. This is appealing because you can come back in half the time. And of course, in professional baseball, that's huge. You know, coming back in half the time, you don't necessarily have to miss a whole season like you do now. Now you can potentially get hurt and come back the very next season, where that's just not possible at this point. Okay, so I'm going to give you just a few principles on how we think we might be able to prevent some of these injuries, or at least, you know, not prevent them, but decrease the injury risk of getting these injuries. One is the obvious: improve your pitching mechanics. So remember, we measured various torques in the laboratory, 64 to 100 Newton meters of various torque to resist the valgus. I showed you the valgus that goes on in pitching. Well, you need a varus torque to resist that, to neutralize it, so you don't basically have much of it. And it's kind of equivalent to holding a 20 to 30 kilogram dumbbell in your weight in this position, or 40 to 60 pounds. There's a lot of internal rotation torque that's needed to control this external rotation that produces the varus. So muscle conditioning is very important. All the muscles, like the shoulder internal rotation muscles that have to fire eccentrically in this phase, the lats, the pecs, the subscap, very important to have proper strength and conditioning. So the torque has very well may influence the UCL injury risk. So that's why we measure varus torque. That's why we're interested in varus torque. Tomoyuki Matsuo, who's in the audience and who's a professor here at Osaka University, and who invited me to speak, he did a very nice study looking at the influence of shoulder abduction and lateral trunk tilt on peak elbow varus torque for college baseball pitchers. And he did this a little while ago, but it's still so applicable today. We did another study based on some of the work that Tomo did, knowing that contralateral trunk tilt is important, to look on shoulder and elbow risk in pitching biomechanics in professional pitchers. Of course, Dr. Fleisig, that Tomo, Yoshi, and myself all worked with together, looked at the kinetics and implications about injury mechanisms. And of course, Dr. Ant, who was a fellow at the American Sports Medicine Institute in Alabama, looked at the correlation of torque in elbow injuries in professional pitchers. So there's a lot of data now, getting to be more and more data, that we're starting to really believe that varus torque does influence UCL injury risk. So that's why we measure it in the clinic. Where is this varus torque coming from, you may ask? Well, this gives you a little bit of a picture. It's kind of a busy slide, but it shows you forces and moment arms produces moments or torques. And that's where the various torque needs to be generated to resist valgus. Remember, a valgus torque is generated just by the act of pitching. This producing tensile loading on the medial elbow and compressive loading on the lateral elbow. But the medial elbow, that UCL ligament is actually, or the UCL, is actually going to produce a tensile force distributed over a moment arm, produces a varus torque in the opposite direction, as you see right here, as this valgus torque. And then over here is a radial head. Remember, this is going into compression on the lateral elbow. The radial head exerts a force on the capitulum. The capitulum exerts an equal and opposite force on the radial head. That's distributed over a distance. We call that a moment arm. And that force over that distance produces a varus torque. So osseous structures, the radiocapitellar joint in particular, helps unload the valgus torque. And lastly, this is something we can control in strength and conditioning, in kinesiology and physical therapy. We work a lot with this, is this flexor pronator mass resultant force from muscles. Force over distance produces a varus torque to help unload valgus. So this is a very important one, is working muscles, the flexor pronator mass in particular, and other muscles as well. And I'll talk about that in a bit. So again, getting back to some of the work that Tomoyuki Matsuo and myself and others have done, this shoulder abduction or lateral trunk tail appears to be very important. The strongest position of throwing is about 90 degrees, regardless of whether you're an overhead, sidearm, or three-quarters arm slot. You say about this, what happens as you become more overhead is you have more contralateral lateral tilt away from the throwing arm. And you can see 90 degrees here, and then about 15 to 35 degrees, or an average of about 25 degrees. That's kind of a mean of all pitchers collectively. And this is some of the work that Professor Matsuo did, showing that this really does matter. If you have too little or too much shoulder abduction and lateral trunk tilt, that can result in greater elbow varus torque and potentially a greater risk of injury. For example, at 40 degrees of lateral trunk tilt, so that's a lot. That's your way over an overhead throwing slot. And then your arm is too low or too high. Remember, 90 is about the average. So getting that arm up in the proper position, he found that approximately twice the varus torque was generated compared to a more normal throwing position. So this again, we're talking about arm slot. So there's the 40 degrees right there that Professor Matsuo correlated. And then again, this combined with having the shoulder abduction too low or too high, that can increase the varus torque. Now, again, in the literature, does this increased arm slot by itself increase the varus torque? I put a question mark here. So this is a study that we did and published recently. And you can see overhead, three-quarter, and sidearm. And we really found that the varus torque was not the highest here. It was even slightly higher in the three-quarter position. However, there's other studies that have shown that it is higher here, but it's a little difficult to compare the results of some of the other data that you see up here, because some of the studies didn't completely quantify what is an overhead slot, or was a very large range of numbers, where we try to narrow it down a little bit on our range, as you see here, our arm slot, just to make it a little more concise. So the trend seems to show perhaps this overhead throwing slot does have a little more increase in elbow varus torque, which may increase UCL, but it's inconclusive at this point. But we know it's somewhere probably in here. It is probably not here at this the sidearm throwing. And there's also the influence of tall and fall versus drop and drive styles of lead foot contact on UCL reconstruction and Major League Baseball pitchers. So you can see here of the 223 UCL reconstructions, 3/4 of the pitchers use this technique. It's called a tall and fall pitching style. The pelvis above the lead knee and the lead knee more extended. Compared to 1/4 of the pitchers that use a drop and drive style. The pelvis below the lead knee and the lead more flexed. So you can see the knee is more flexed and the drop and drive, straighter, more extended here. And the pelvis is higher, pelvis is lower. So that was interesting to show some of the differences there. And then if we look at other data, here's some of your Japanese colleagues reported greater varus torque in American pitchers who primarily use the tall and fall compared to the Japanese pitchers who primarily use the drop and drive. So very interesting conclusions they found in that study. And also, not only that, but adequate shoulder flexion and internal rotation range of motion. So these are things that we routinely do in physical therapy. We measure how much shoulder flexion do you have, how much external rotation do you have. And they reported that shoulder external rotation and shoulder flexion deficits are independent risk factors for developing elbow injuries in professional baseball pitchers. The risk of elbow injury increased by 7% for each degree of decreased shoulder external rotation. So it's very important. We have norms now. We know that the external rotation in a shoulder is about 120 to 130 degrees in professional pitchers. If you don't have enough, or if you have too much, they can both be problems. If you don't have enough, you're not going to be a hard thrower. And also, each degree of decreased shoulder external rotation you have seems to increase your elbow injury risk as well. And 9% for each degree of decreased shoulder flexion. So again, having enough shoulder flexion up here and external rotation of the shoulder, these also affect elbow injuries. All right, so all those slides to show you that pitching mechanics matter. And we need to be able to look at pitching mechanics. That's principle number one. Principle number two is to help potentially prevent injury is don't throw so hard. Now this might sound funny at first. What do you mean don't throw so hard? But it's actually a study that was done. You want to avoid Tommy John surgery? Don't throw so hard. So the harder you throw is an independent risk factor to UCL injuries. And we believe that's part of the reason of the epidemic in our youth as well as professional pitchers. They're throwing much faster now in our professional leagues in America and in your Japanese leagues, professional leagues, same. Throwing much faster now than they used to, 10, 20, 30 years ago. And we believe that's contributing to the injuries. But of course, throwing faster is many ways helpful because it helps get the batter out. But there's ways you can manipulate this and not throw hard all the time. And that's important. In other words, you need a good off-speed pitch to go with your fastball. So principle number three is vary your pitch times. Don't always throw hard all the time. So we started doing some studies with this. Here's a study that I published a few years ago, looking at pitching mechanics among the fastball, slider, curveball, and changeup. Looking at kinematics and kinetics. And here's what we found, or one of the things, elbow varus and flexor torque is significantly greater in the fastball and curveball compared to the changeup. So the changeup really is an excellent off-speed pitcher that may save the elbow a little bit and decrease the risk of injuries. Here's Dr. Pleisig doing another study, similar study, looked at a different population of pitchers in this one, college pitchers, where the study I showed you that I did was professional pitchers, but they found similar results. Elbow torques were greater in the fastball, curveball, and slider compared to the changeup. So again, the changeup really in all the literature has the least amount of loading, and the fastball, slider, and curveball seem to have similar amount of loading. So really tells you that maybe the changeup is a really important pitch. Are certain pitches more stressful? What about youth pitchers? So here's a study that was done again at the American Sports Medicine Institute. You're looking at kids, young kids, 9 to 14 years old. They found that the curveball and slider produce more elbow pain. The changeup requires different mechanics, but low elbow stress levels made it a good off-speed pitch. So we really believe the changeup should be a pitch that young kids start working on mastering to go with their fastball, because you always need a good off-speed pitch to go with a good fastball. Pitch combinations, again, this is basically summarizing what I just said. The fastball and changeup might be a good combination as opposed to a fastball and curveball. They're off speed, the curveball's off speed, but the loads at the elbow are similar in the curveball compared to the fastball, where they're much less at the elbow in the changeup compared to the fastball. All right, and when do you start throwing these pitches? I don't know about in Japan, but in our country, we try to emphasize starting the fastball very young, and I think that's similar to Japan, and then the change up at about age 10 instead of age 8, the curveball a few years later, so delay in the curveball to 14, and the slider to age 16. These are recommendations a committee made of experts in order to decrease injury risk in our youth. And of course, who's doing that? You know, are people following the recommendations? Probably not, because most pitchers in America and in Japan start throwing the curveball well before they're 14 years old. So it's probably not following the recommendations, but that might be why there's getting to be more injuries in our youth. Are mechanics different among these? Yes, there's many studies you see up here that show the mechanics are different between the fastball, the slider, the changeup, the curveball. Elbow forces and torques are generally greater in the fastball, again, compared to the changeup and curveball in the summary of these studies, and significantly greater in the curveball compared to the changeup. So again, if you look at all the studies in the literature collectively, this is kind of a summary of what we're finding, but it shows again the changeup has the least. So most studies show that throwing the curveball does not result in higher risk of elbow injury compared with throwing the fastball or slider like we used to believe. Although if you throw it incorrectly, it still could. So we have to always be careful of how we interpret the data in the literature. The changeup, again, is the best option for a good off-speed pitch if you want to minimize the elbow loading that's going on and potentially decrease injury risk. Here's a study that reported Major League Baseball who threw a greater number of different types of pitches decrease their risk of having UCL reconstruction. So again, varying things out, not throwing hard pitch after pitch after pitch after pitch. And then lastly is pitch volume and intensity. Very important. Here's again a study of youth, and they found when a pitcher threw with arm fatigue, they were 36 times more likely to be in an elbow surgery group as opposed to a non-surgery group. So not throwing to your fatigue, overuse type problems. When a pitcher engaged in more than 8 months of competitive pitching, he was 5 times more likely. When I was a kid, and probably the same with Yoshi and Tomo because we're all about the same age, they didn't have year-round baseball, at least in my country. Japan, year-round baseball when you were children, kids? Tomo, Yoshi, year-round baseball? No? Yes? Yes, year-round baseball. Okay, so a little difference between our countries. My country, they didn't have year-round baseball. Now they do. And now we're seeing a lot more injuries, we believe, because the elbow is not allowed to rest. We're pitching every month of the year, all 12 months of the year, we're throwing. And we strongly believe, and the research shows that when a pitcher engaged in more than 8 months of competitive pitching during the year, he was 5 times more likely to be in an elbow surgery group. So taking time off, doing other activities that are gonna let the elbow rest. Not throwing too many pitches. When a pitcher threw more than 80 pitches in a game, he was 4 times more likely to be in an elbow surgery group. Oops. And when a pitcher self-reported he threw more than 85 miles an hour, he was 2.5 times more likely to be in an elbow surgery group. So again, hard throwing makes a difference as well. Overuse in the professional ranks, overuse in the youth, overuse, we really believe is a huge problem in fatiguing the muscles fatigue, they can dissipate energy as well. And you're gonna be more likely to overload the tissues that cause an injury. And the last principle, have a good year-round strength and conditioning rehab program to minimize some of the loads that's occurring at the elbow. So you can see, again, the loads at the elbow are a lot. So here we took one of our cadavers in our laboratory, and we loaded the shoulder into the arm cocking phase, as you see right here. We highlighted the anterior bundle of the UCL in purple. And then as you go into max external rotation of the shoulder, we took a little instrument here, as you see, to push on it and show how taut it is. And research has shown that this UCL resists about half of the valgus loading that occurs statically, about half. If you do the math, about half of the Newton meters, it looks like the in vitro strength is about the same as failing. It's about to fail every time you pitch. But that's not the case, because this is really important to realize, this is a cadaver. So the UCL is loaded maximally, but there's no muscles. So muscles are very important to help unload the stress on the UCL. The flexor pronator mass that we talked about in particular, as you see here. So that's an important point to remember. The flexor pronator mass generates a varus torque that resists valgus, thus unloading the UCL. However, weaker fatigue muscles can result in injury risk, increased injury risk. So we really want to be careful of that. Remember, we said it's not just the UCL, it's the radiocapitellar joint that's producing a varus torque as well. That's a good thing. And then the dynamic contributions to the varus torque from the muscles. And it's not just the pronator teres and the flexor carpi radialis, flexus carpi ulnaris. Let's not forget about the finger flexors, the flexor digitorum superficialis, as well as the brachialis even. They've shown to contribute to dynamic stabilization. You can see several studies down here that have shown that. The elbow flexors are not real active, but you have much more activity from the flexor pronator mass as well as the finger flexors. So we need to work the wrist flexors, the finger flexors, pronators, terry muscles. And then of course, balance on the other side of the joint, working the supinator extensor mass as well. Proper strength and conditioning becomes very important in this. Here's some research study right here from Roshuki, reporting 2 tendinous septa, let's call that the TS, found between the pronator teres and the flexor digitorum superficialis, and also between the FDS and the flexor carpi ulnaris. These two are connected to the medial part of the brachialis tendon, along with the deep aponeurosis of the finger flexors and the flexor carpi ulnaris, which along with the joint capsule link the humeral ulnar joint. So this is really important. They showed that these muscles, as well as the finger flexors, were combined together to form the common tendon of the proximal origin. And the common tendon was attached to the anterior bundle. Remember, it's the anterior bundle of the UCL that is injured with excessive valgus at the elbow that results in Tommy John surgery. And you can see it here in the schematic. the different wrist flexors and the finger flexors and the pronator teres. All these muscles collectively work together to transmit muscle power to the humeral ulnar joint via this tendinous complex, similar to how a sailboat, if you will, transmits the wind to power the ship. So injury prevention data for working, all the muscles in the flexor pronator mass become very important, as well as even the elbow flexors, to help minimize injuries of the UCL. Strength and conditioning, again, becomes very important to help minimize these injuries. Practical guidelines to help can be found in this paper. This is kind of a summary paper, how to prevent UCL injuries. If you're interested, you can look up that paper in the literature. Okay, we're kind of starting winding down my talk now. We're talking just a little bit about the radiocapitellar joint. Again, the radial head, there's going to be compression here because of the valgus. It's going to produce a force on the capitulum. By Newton's third law of motion, the capitulum produces an equal and opposite force on the radial head. That's distributed over a moment arm, as you see here, and that produces a varus torque to unload valgus. So that's a good thing. The bad thing is the force here is about 500 newtons or 50 kilonewtons. So that over time can lead to osteochondritis dissecans, where the cartilage starts degenerating and the blood supply can also start degenerating. And you can appreciate it here if you look at this picture. We're looking at a cadaver in this same arm cocking position, and you can see here, as we zoom in a little bit, there's a radiocapitellar joint, and it's under very high compressive loads that produce over time, wear out this cartilage, degenerate the cartilage and the blood supply, and that results in osteochondritis dissecans. So that's a problem, and you can see the result as the cartilage degenerates, the blood supply degenerates. Then you can see it on a radiograph, the degenerative changes that's occurring to the subchondral blood supply as well, and you get osteochondral lesions, and as well as loose bodies. This chips out, and then you get loose bodies around the elbow as well. So that's a problem. Arm acceleration is a very fast motion, and the elbow extends really fast. This is faster than you can do from a concentric muscle action alone. It's all the energy coming up the chain from the legs to the trunk that extend the elbow over 2,000 degrees per second. And it's the elbow flexors, like the biceps, that have to slow that down. So again, it's very rapid. And arm deceleration, slow down that motion, can cause other injuries in the elbow, such as slap lesions as well. So if you look at the elbow, the biceps are contracting, but they attach the long biceps attaches up here to the labrum. So here we're going to electrically stimulate the biceps, and then we're going to look inside the shoulder with the scope. And here it is. The biceps, the long biceps contracts, it's pulling on the labrum. It's trying to pull the labrum off the glenoid. And repetitively overuse, that's a problem. That can cause a superior labral tear that's anterior and posterior in direction, known as a slap lesion. And that's what you see right there at the shoulder. So again, even though it's at the elbow, there's a long biceps, there's a labrum, and there it can try to detach it off the labrum every time you pinch. So again, overuse can be a big problem as well. The biceps have the greatest activity during the arm deceleration phase, about 44% of a max contraction. They fire eccentrically to help slow down that rapid elbow extension. High compressive forces also occurring at the elbow. A flexor torque generated, like we said, the elbow flexors have to contract eccentrically to slow that down. Elbow extensors as well. Proper strength and conditioning, very important. And again, during the arm deceleration phase, the flexor pronator mass, the extensor supinator mass, very active. So I mentioned this a lot, proper strength and conditioning of these muscles. If they start fatiguing, they can't dissipate the energy as much, then the static tissue like the UCL is gonna take more. And my final couple slides, and I'm done, is the last thing that can help it at the elbow is impingement of the posterior medial olecranon with the posterior medial olecranon fossa as the olecranon moves within the trochlear groove, as the elbow moves into valgus. It's a little hard to picture this just by looking at this motion here. You have to really look inside the elbow to see the impingement of the olecranon in the trochlear groove as it moves in the olecranon fossa. So here you can see it. Here's the triceps here. Here's the olecranon. Here's the trochlear groove that the olecranon is going to move in. As you go into valgus, this moves posterior and medial. And you can get stress as it moves into the olecranon fossa right here. And that can cause bone spurs to occur. And those bone spurs can chip off. So again, with overuse, or too much valgus. Again, valgus can cause a lot of these problems. You can get, here you can see it even better. Here you can see there's the stress in the bone. As you go into valgus, it's going in the posterior medial direction. And you can get posterior medial osteophytes and loose bodies as well, which is a problem. This is what it looks like. So this slide puts it all together. There's a medial contention, a medial tensile loading rather, you're gonna get in the medial side of the elbow, in the UCL, and you can also get ulnar neuritis from it. On the lateral side, at the radiocapitellar joint, you're getting very high compressive loads that can cause osteochondritis dissecans. And then finally, the last slide I showed you, bone spurs from posterior medial stress can chip off, and that can cause posterior medial osteophytes and loose bodies to occur as well. It can all be exacerbated by excessive valgus as well. So in conclusion, poor pinching mechanics or muscle weakness or fatigue can result in increased elbow force and torque, subsequent increase in elbow injury risk. Repetitive force from the biceps brachii from overuse can lead to slap lesions. And UCL insufficiency of the pronator flexor mass, muscle weakness, fatigue, strength and conditioning becomes very important as well. Repetitive valgus loading at the elbow can lead to injuries, osteochondritis dissecans, and posterior medial injuries, osteophytes, and loose bodies. And again, I've said it many times, proper strength and conditioning becomes so important as well. Here's a few of our papers that we have published over the years, just a few sample papers there. And with that, I've taken 54 minutes. So I was supposed to do it in an hour. I guess I accomplished my task. So I thank you very much again for your attention.
Thank you very much, Professor Escamilla. Because of your very quick English, so you could finish the presentation at time.
Yeah.
Time. Are there any questions, everybody?
Yes, thank you for your lectures. You showed some principles for preventing injury in this time. And I want to know the most important principles for preventing injuries.
Most important
important principles for
principles. Yes.
for preventing elbow injuries
Yes.
in adolescent pictures.
At-risk pitchers at the elbow injuries. Yeah, the most important, and I don't know if one's more important than the other. That's why I kind of listed the 5 principles. Improve your mechanics, have your good shoulder mechanics. And there's more and more literature showing things like inadequate shoulder external rotation, inadequate flexion. In different ways that you pitch that increase loads in and of themselves of the elbow. I think as a physiotherapist and a researcher, strength and conditioning I think strength and conditioning, if I had to pick one principle, is, in addition to throwing with good mechanics, I think is crucial. And overuse. So you put that together, overuse injuries, limiting how many, you don't do year-round baseball. The ones that do year-round baseball are going to be more susceptible. And most of them are never going to make it to the very high levels. We found, at least in our country, we found all the best pitchers in the Little League World Series around the world. Very few ever make it to professional baseball, ever. So we feel a lot of those Little League World Series pitchers, they pitch year round and they start very young as kids. And we feel that really decreases your chances of performing well for many years after youth, if you're going to go on to college or professional ranks. So having better pitching mechanics, good strength and conditioning program, not pitching year round, not pitching too many pitches in a game, in a season, overuse injuries, and varying pitch types. Not throwing the fastball all the time, having a good off-speed pitch. Those are 4 principles that I think are the most important to decrease your risk of injury beyond.
Thank you so much.
You're very welcome.
Okay, thank you for presentation. So I could ask some question in last week conference. Therefore, I have an additional question. So you presented about the importance for muscle contraction, the flexor and pronators.
Yes.
So flexor and pronator muscle is needed to coordinated contraction during the pitching.
What was the word?
Collaborated.
The other muscle?
Yes, so the flexor
Flexor pronator?
and the pronator muscle. So, by the way, so how, what kind of training your recommendation for
Training.
Yes, training,
Yeah.
including the around here.
Strength and endurance.
Yeah.
So as a pitcher, you need adequate strength. You have better strength, more force over a moment arm, more torque, more Bear's torque to unload valgus. And in pitching, you do repetitive. So you have to work on some muscle endurance as well. So in your strength and conditioning program, you train principles of strength training and principles of muscular endurance training. I think both those are very important for the whole body. And I focused on here, right? But we know, if I had another hour or two, we know the importance of working the whole body, the legs, the trunk, and working these muscles that are generating all the energy, we know are very important as well.
Yes, thank you.
You're very welcome.
So we got a question from the online.
Yes.
And from the online question, that may I ask about the influence of folklore?
But
Sweet finger part for.
3 finger.
No, split finger.
Oh, yeah.
And is the influence similar to first ball or not? And what recommend for the young pitchers? It's a question from online.
That's a great question. And this is what we're really starting to do now, and is look at other pitchers, because and that's what we're starting to do now in our research. Is we started off with the fastball, the slider, the curveball, the changeup, right? Because those traditionally are the most common pitches. But now pitchers, as we all know, they throw so many other types of pitches with split finger and other things, and different types of changeups and different types of fastballs and sinkers and all kinds of other, even sliders are changing the way they throw the slider. And we don't have any data. We haven't studied those other pitches yet. So this is what we feel in the future, as the game of baseball keeps evolving. We have to keep up with that evolution of baseball and keep studying the things that are being done. Because if we don't keep up with it, then we won't be able to answer the questions that are being done now in the way they're throwing now. So it's that's a future. We don't know. The answer to the question is we don't know. No one's ever studied that I've seen. I haven't seen the literature. I haven't seen that come up. Maybe it's come up recently, but I haven't seen it yet. But I haven't seen the biomechanics of the split finger specifically looking at loading at the elbow in particular. So I think that's something that we need to study in the future.
Thanks.
Another thing.
Please, Dr. Inohida from online.
Oh, thank you very much. Thank you very much for your presentation. I enjoyed a lot. Very interesting.
Thank you.
I'm studying twisting modern mechanics, and from this mechanics point of view, I think that the more linear type of movement produce energy to add speed to the ball. In such case, the torque around the elbow may different between pitcher and pitcher. What do you think?
Yeah, he said more linear movements. Did you say more linear movements?
Yes, twisting model mechanics imply that it makes a more linear type of power at the throwing. So in such case, I'm guessing that such mechanics may help to reduce the burden of the elbow, torque around the elbow, and help prevent injury. And
When he said linear, is he talking about?
injury around the
Did you say
elbow.
linear transformation?
No. Mostly, according to twisting model mechanics, there's a more linear type stress gives the power to the ball, the energy, not rotation. In such mechanics, the energy torque burden on the torque, which may cause the injury, may decrease, I think. So I simply thought the torque you showed on the presentation may different between every pitches, every move, every pitch. What do you think?
I'm sorry. I think that twisting, you said twisting model.
Yeah, twisting model.
Yeah, it is very unique, your own unique model. So I think that Professor Raphael don't know the twisting model.
Right.
Oh, okay, thank you very much.
Yeah.
Actually, not my own model. It is already published on Baseball Research Journal almost 10 years ago. So if you are interested, please have a look. Thank you.
Okay, thank you.
Yeah.
He has a published paper about the testing model. So
Okay.
introduce.
Yeah,
Yeah, please send me that. I would like to see it. I'm not familiar with it, and I apologize for that. But I would like to see it if you would mind emailing it to me, and then I can in return, I'll send you a couple, you mentioned energy transfer, I think, a little bit. I'll send you a couple of our papers on energy transfer up the chain in return. So, but thank you.
Thank you very much.
Other questions?
Thank you so much. And I want to ask about why the half amount of catchers can back to the previous level of play.
Right.
So it comes from their throwing strategy or something specialty of their play.
Right. Yes, interesting catch. So yeah, so one of the slides I showed, just to refer what you're talking to, is I had pitchers and catchers and infielders, outfielders, and it showed their return to the same level. And the pitchers were closer to the 80%, the catchers were about 50%. And you're asking why the catchers are only 50%, is that correct? Okay, good. That's a great question. Now, here's the thing, why we're confident with pitchers, is we've seen so many more of them. We've only seen a very select few of catchers, and not only that, but if you look at the research, that particular research study, you're gonna be hard pressed to find another one on catchers, right? So there's such limited data, whenever there's that little amount of data, then when you're looking at percentages, it may not be, there might be a lot of other variables in there, right? Like if you looked at 1,000 catchers versus only 30, right? And 30, it may just be, who knows, right? It's not a big enough sample. Well, with baseball pitchers, we have such an enormous sample now, thousands, literally, in the literature, that we know, we're pretty confident we know the outcomes. So with catchers, there's so few, we just don't have a big enough population. And, this particular study showed 50%, but if another one was done, they might show 75% or 80%. So you need more research on that that's why you always have to be careful with research, that you read one paper, you don't want to infer more than you can with that one paper. You start seeing a bunch of papers, then you can make better inferences. Yeah, good question. Yeah, good catch. Yeah, you're welcome.
All right, now time is 10 minutes over. If you have questions, I will accept just one last question.
Thank you for your great presentation. And as you explained, and I think the elbow bar stroke, the value of elbow bar stroke and the number of pitch is a good indicator for estimating the elbow injuries.
Yes.
Yes. And is there any difference, the combination of the value of elbow bar stroke and the number of pitch? For example, and the pitcher indicates the high elbow bar stroke, for example, 100, and it is recommended, for example, 50 pitch is good, for example.
Yeah, that's a good question. You're talking about if they have a higher elbow varus torque, are they more likely to get hurt? And the limited data we have now seem to suggest there's a trend that way. Again, I'm careful as I was in my slide, where I said there seems to be a trend, but you have to do correlational studies and other types of studies to really, and that in itself isn't going to prove it either, right? And so there's a relationship, doesn't prove causation, but there's at least a trend in that direction. So we feel that there is a link, and that's why we measure it, but we still don't know for sure. We still don't know for sure that just because you have a high varus torque, that you have a much higher risk of being injured, and if so, how much higher? Where's the cutoff? And so there's so much we don't know at this point, but that's the exciting things of science. As we continue to do this research, we get more and more data in that area. But even with the varus torque, it's hard to make definite conclusions that it's definitely tied in with injury risk. But we believe it is. We believe there's enough data from the studies I showed you. There's not that many, but there's a few that have looked at that. Dr. Hans in particular is probably the best one that really looked at the relationship between actual people that got hurt and measured torques and stuff. So yeah, it's ongoing research is the fun part of our job that we do, that we love as researchers to keep doing this, because for every question you answer, you think you answer in research, it opens 10 more questions that you need to say.
Thank you.
That's why we're glad for all of you in the audience, and some of you are students, and a few of you anyway, and probably online, and you're doing your PhDs. This is exciting, right? For you, as you do your PhDs, then you have a whole career ahead of you to answer some of these newer questions. When Professor Letsuo and Professor Takada and myself will be retired before too long, and we'll be sitting on a beach somewhere, hopefully relaxing, reading your papers, and proud of you. So keep up the good work, all of you. And I met many at the physical therapy conference as well a couple of days ago. It's very exciting to see all the young people coming out to do the research, and especially now, because of, like I said, when we first started, there was hardly any research, and our technology wasn't even that good. And now the models, the technology is so much better. So I think the people coming up now, it's going to be very exciting to be able to do the research.
Okay, thank you very much. The seminar now will wrap up this seminar.
Yeah.
Okay.
Oh, I might say too, my email, I think, was on there. Was that the first slide on there? I don't know if my email was on there or not. But feel free to email me, all you people in the audience listening, if you want any of my, let's see if it's on there now.
Oh, sure.
Yeah, there's my email, RS, they can see that, right? And online people.
Oh, yeah.
Yeah, so if anybody wants any articles or wants information, or you have questions, or you didn't get to ask a question, feel free to email me. I'm usually very good at responding. And if I don't respond, then email me again, because occasionally I get so much junk email, I delete accidentally. And, but I will respond if you email me.
OK。先ほど質問していただいた今平さんかな、ここに、ぜひ論文を送ってください。
ありがとうございます。
ということで、このセッション、sorry. Okay, let's wrap up this session. Okay, thank you very much. Thank you. オンラインの方もこれで終了ですので、ありがとうございました。お付き合い。